I'm going to move a little more quickly than usual, because I want to cover a fair amount of material. Just to start with, I have no disclosures. And I was involved. It was involved in the DSM-5 process with the work group for mood disorders as an advisor with a particular focus on bereavement and bereavement exclusion. And we'll talk a little bit about that today. What I'm going to talk about, basically 4 parts in my talk: NOS disorders in general, and specifically as they relate. Oh, sorry about that.
Okay, is that working now? Okay. Okay, we're good? Okay. I don't need to start over again, do I? Okay, good. If I'm too loud, because I tend to not use a microphone, maybe that'll help. Okay. Can you hear me? Okay, and that'll work for the, okay. So the DSM talks and many of the other grand rounds this year we're going to be recording, so a new phase in our development as a department. So I'll talk a little bit about NOS disorders, bipolar disorders, depressive disorders, and what happened with suicide in the DSM-5. First of all, the NOS disorders, the main change in NOS is that they're gone. There's no longer such a thing as depression NOS, anxiety NOS, or anything NOS. Interestingly, in DSM-4, there were actually 74 separate subcategories of NOS disorders. 54 of them were in the text themselves in the various diagnoses. 13 of them appeared in Appendix B with specific criteria, but were still NOS disorders, which was somewhat problematic. In DSM, I'll tell you a little bit about why. Okay, so the shifting, so there's a separation. They're no longer considered 2 extremes of the same general diagnosis. A lot of us would think of bipolar as being a more severe form of the general mood disorder, depression, but very psychotic melancholic depressions could be every bit as severe as some bipolar disorders. So that didn't necessarily make sense. So now they're separate. They're 2 separate disorders. The bipolar disorder comes first in the DSM, and that's intentional. It's a bridge between the schizophrenic spectrum and other psychosis disorders and depression disorders, with the idea that genetically, phenomenologically, in terms of course, it is betwixt and between, and maybe every bit as related to the psychotic disorders as it is to the depressive disorders. And the depressive disorders are a bridge between the bipolar disorders and the other internalizing disorders, such as anxiety disorders, which comes next. And so that comes from some of the biological and genetic research, actually. The bipolar disorders include 7 conditions: bipolar 1, bipolar 2, and cyclothymia are still there. Substance, medication-induced bipolar disorders is still there. Bipolar and related disorders due to another medical condition is still there. That's renamed, by the way. So when a disorder is considered secondary to, let's say, hypothyroidism or thyroid disorder, no longer is it kind of thyroid-induced or hypothyroid-induced. The idea is that this is a bipolar disorder that is due to another medical condition, suggesting that the mental disorders are every bit as legitimate as any other biomedical disorder. And then finally, there's the unspecified and specified disorders. The key changes, one probably the largest change in the bipolar disorders, is that the A criteria, the fundamental criteria by which the diagnosis is made, now includes activity and energy. And that, again, came out of data that increases in energy are a fundamental component of manic and hypomanic episodes. Every bit as important as the mood changes. And so the A criteria now reads a distinct period of abnormally and persistently elevated, expansive, or irritable mood. That's same as DSM-5, and abnormally and persistently increased goal-directed activity or energy, lasting at least a week, present most of the time, nearly every day. Not necessarily a week if hospitalization is necessary. Okay, so energy, low energy, or high energy, and increased activity are now fundamental aspects of bipolar disorder. Okay. Another key change is that the mixed episode is no longer there. So the DSM-4 diagnosis of bipolar 1 mixed episode, requiring that an individual simultaneously meets criteria for both mania and major depression, has been removed. And instead, there is a new specifier with mixed features that is present for both bipolar disorder as well as depressive disorders. Okay. The full criteria is so in terms of the bipolar disorders, with mixed features is used when a patient meets criteria for mania or hypomania, but also has at least 3 depressive symptoms. And the depressive symptoms are listed here: prominent dysphoria, anhedonia, psychomotor changes, fatigue, etc. So in the context of mania or hypomania, if you also have 3 or more depressive symptoms, you now have mania or hypomania with mixed features. The depressive features need to be observable, so it's not just a report, but it's something that you can observe, and it has to be a change from one's normal behavior. If full criteria for both mania and major depression are met, the diagnosis in that condition should be manic episode with mixed features. Okay.
Was insomnia considered
So,
as an associated symptom?
was insomnia considered? So let me go back. They specified that it would have to be these. So insomnia would not be one of the 3. Now you could have insomnia as long as you had at least 3 of these.
Some feature in depression.
Right. But it's so common and also part of being manic or hypomanic that they felt it didn't distinguish a mixed feature. So because it's so common, but also present in mania and hypomania, they felt it didn't distinguish, although the vast majority of people who have mixed features are going to have insomnia as well. But they could have hypersomnia. Okay. Another key change, and this is true for both depression as well as bipolar, is an anxious distress specifier. And I'll talk about that a little bit later. I'm going to put that aside for now. The 3 other specified bipolar and related disorders are short duration. So if somebody has hypomanic episodes lasting only 2 to 3 days, remember, hypomania you need at least 4 days. If they last only 2 or 3 days and the person's had major depressive episodes, that would be other specified. So that would be something that with diagnostic criteria they could be coded. Hypomanic episodes with insufficient symptoms. This would be less than 3 symptoms in addition to the mood change of depression. And hypomanic episodes without prior major depressive episodes. So you can't have bipolar disorder, type 2 in the absence of having depressive episodes. You can have bipolar type 1 and never have been depressed if you have recurrent mania. But if you have recurrent hypomania, that's would be one of the other specified bipolar disorders. And then short duration cyclothymia would be other specified as well. That is, mood swings lasting less than a day. Okay. Shifting over to depressive episodes, there are more changes in depression than there are in the bipolar disorders. There are 8 syndromes listed under the depressive disorders. A new one that I'll talk about, disruptive mood dysregulation disorder. There's major depressive disorder, persistent depressive disorder, also another new one, we'll talk about that. Premenstrual dysphoric disorder has made it into the primary diagnoses. And then the substance abuse, the due to other medical conditions, the other specified and unspecified. As I mentioned, these are now separated from bipolar and related disorders as a bridge between bipolar disorders and other internalizing disorders, specifically the anxiety disorders. The common features are sadness, empty, irritable mood, accompanied by both somatic and cognitive changes that significantly affect the person's ability to function. And each of these categories basically differs by issues related to duration, timing, and or presumed etiology. So first, 3 new disorders: disruptive mood dysregulation disorder, premenstrual dysphoric disorder, and persistent depressive disorder. Disruptive mood dysregulation disorder, which some of the data related to this are studies done with a different term, severe mood dysregulation disorder, SMD. But the rationale for this was the dramatic increase in diagnosis of bipolar disorder amongst children and adolescents that nobody was comfortable with. In part, irritability was the core symptom that led the diagnosis of bipolar disorder being used so frequently in children and adolescents who are often irritable, and that is something we see with bipolar disorder, irritability. So some studies were done to look at patients who, as children, were being diagnosed with bipolar, who had the severe mood dysregulation. And basically, and Dr. Ming, I'm sure, can comment on this, genetic studies, phenotypic relationships of irritability in children was linked much more with depression than it was with bipolar disorder. And as these children grew up, they were at high risk for major depressive disorders and anxiety disorders, but not at particularly high risk for bipolar disorder. And biological studies looking at the amygdala and imaging with facial expressions, et cetera, showed that these children actually were different than children with bipolar disorder or controls. And again, similar to what we would see in major depressive disorder. There was a recognition, though, that this syndrome was real, it was impairing, it was chronic, and that these children often did grow up to have major depressive disorder or anxiety. So there was an interest in capturing it, and the decision was made that because of its closer association with depression, that it would be one of the depressive disorders. So brand new diagnosis, which probably is fairly common. There really haven't been great epidemiologic studies, but this may be something in the ballpark of, I've heard 3 to 5% of children. I have a feeling that's a little bit high, but it's probably not uncommon. It's the key characteristics, which we see on the left, are temper tantrums. So verbal and or behavioral anger outbursts, severe anger outbursts that are out of proportion to developmental issues, to provocation, that occur at least 3 times weekly, or on an average of 3 times weekly, over an extended period of time. In between temper tantrums, irritability is the general persistent and observable trait. And it has to be observable and impairing, significantly impairing, in at least 2 settings. At home, at school, with peers, and in at least one of these settings, the impairment has to be rated as severe, and in at least one other as at least moderately severe.
There's at least one setting.
It's severe in one setting. So it has to be present in at least 2 settings, severe in one, moderately severe in at least one other. Okay, so I may have cut some corners in trying to make this legible. And it has to be there for at least a year without a 3-month period absent of temper tantrums. Okay, and it can't exist with oppositional defiant disorder or intermittent explosive disorder, bipolar. So if you meet criteria for this and meet criteria for bipolar disorder, you have bipolar disorder. You don't have both. If you meet criteria for this and oppositional defiant disorder, this is the diagnosis to go with. And the oppositional behavior is considered secondary to this diagnosis. So that's a brand new one that the child psychiatrists, I'm sure, will be becoming very, very familiar with. It's meant to be diagnosed during a certain age period that has to occur by age 10. The first episode that counts is after age 6 and before age 18. Okay. The next new diagnosis, premenstrual dysphoric disorder, is not new to us because it's been there in the appendix in DSM-5, but again is now elevated to a major mood disorder. Criteria A, the majority of menstrual cycles, at least 5 of the symptoms must be present in the final week before menses, after ovulation, improve at cessation of menses, and be diminished or absent by the week after. There has to be 1 or more of these symptoms of dysphoria: marked affective lability, marked irritability, marked depressed mood, hopelessness or self-depreciation, anxiety, tension, feeling keyed up. And there also has to be 1 or more of these category C symptoms, which are basically somatic symptoms, for a total of 5. And those include decreased interest, lethargy, decreased concentration, marked changes in appetite, sleep disturbance, feeling overwhelmed or out of control, and physical symptoms such as tender, swollen breasts, joint or muscle pain, bloating, and weight gain. The symptoms have occurred most periods of the year, must be significantly distressing, not just an exacerbation of another disorder. So if you have major depression, but symptoms get worse during this phase, there wouldn't be a separate diagnosis. It would still be major depressive disorder. And must be confirmed. This is an interesting one that most of us probably don't do and probably should. That the diagnosis must be confirmed by prospective daily ratings of at least 2 cycles. Again, I think it's something that many of us don't do. We use history alone to make the diagnosis. We should have women taking diaries, daily diaries, before definitively making the diagnosis. The next change, and this again is a pretty major one. Be interested to hear what Dr. Judd thinks of this, because some of his area is very, very high, research has been highly related to this. But the DSM-5 has decided to fuse dysthymia with chronic major depressive disorder. The main reason for that is that patients simply can't remember how many symptoms you have 6 months ago and how many not. They don't know. Especially when you're depressed and your memory is already foggy. So making a differentiation between chronic major depression versus dysthymia just didn't work, and most of us didn't pay a lot of attention to it. And it didn't seem to matter much anyway in terms of treatment. The criteria are depressed mood for at least 2 years, maybe irritable, and 1 year for children and adolescents. And at least 2 of the following symptoms, and poor appetite, insomnia, low energy, low self-esteem, poor concentration, feelings of hopelessness. Note that not all of the symptoms of major depression are on this list, which is, I think, a little bit puzzling. Feeling suicidal is not on the list. Feelings of worthlessness are not on the list. Psychomotor agitation is not on the list. So I'm not sure what the justification for that is. But so be it. This is the list. The duration trumps the number of symptoms. So you can meet full criteria for depression as long as you've had it for 2 years, but you don't have to. And it's duration, which is really the key variable here. Specifiers are included, so you can specify, this is a persistent depressive disorder with intermittent major depression, but not current major depression, or it could be intermittent major depression and current major depression, or it could be pure dysthymia. There is a strong suggestion to give the course specifiers along with this. And one of the reasons for doing this is that dysthymic disorder sometimes was just considered minor depression. Don't take it seriously. It's no big deal. And this is meant to elevate chronic depression, even at subsyndromal symptomatic levels, into something that's severe and should be taken seriously. And again, I think Dr. Judd's work was influential in ultimately making this decision.
Having a fair on this, and a little bit orthogonal, is a recent paper of ours that will appear shortly in JAMA Psychiatry about irritability. And we find 2/3 of people with major depression have irritability, and to differentiate children from adults, I think is a mistake.
Yep. Well, but it's consistent, I think. So Dr. Judd, irritability is very common in patients with major depression, even though it's not one of the core symptoms. It's very, and it,
Up until about 20 years ago.
right, and it can be in children.
Yeah.
And we also, in older people, sometimes it's often there instead of being sad and unhappy. And probably ought to be considered an A criteria throughout the life course, as Dr. Judd is saying.
What's really encouraging about this, and it stops short of what's accurate, is the chronicity.
Yeah.
All depressive disorders are chronic, period, even though they may present intermittently.
Yeah. So the point Dr. Judd's making, for those of you who can't hear, is depression is a chronic recurring disorder, period, essentially without exception. Okay. It's a lifelong disorder. Depressive disorders, other key changes, the bereavement exclusion was eliminated. I'm going to talk more about that in some detail. There are 3 other specified depressive disorders. One would be recurrent brief depression. There's been a large literature on this syndrome out of Europe for years and years and years, and it hasn't been as popular or nearly as often diagnosed in this country. But the idea of very brief depressions lasting 2 to 13 days, but not 2 weeks, that can occur at least monthly for at least 12 weeks. So this is now one of the other specified for study, but is not yet in this country considered a major depressive disorder.
Because in Europe, it was championed by Stuart Montgomery for years.
Yeah.
And we don't see it here.
Right. Short duration depressive episodes. So somebody who has depression, at 13 days, do you have major depression, or do you have to wait to 14? And some may actually resolve by 14, and that can be significant, especially if it's recurrent. So short duration is another specified disorder, and the insufficient symptoms. So somebody, having depressed mood plus at least one other symptom is worthy of study. And certainly we see that a lot in the course of somebody with major depressive disorder. With postpartum changes, interestingly, was one of the specifiers has been changed to with peripartum onset. With the knowledge that often individuals who have depression in the postpartum period, the depression started earlier. And frequently it actually starts during pregnancy. And then new specifiers with mixed features and with anxious features. And we'll come to this. So now you can have depression with mixed features, just like you can have mania with mixed features. And then anxious distress. I'm going to talk a little bit more about that. So we'll go through some of these. I'm going to talk in more detail about the bereavement exclusion, about the mixed features for depression, and the anxious features. First, the bereavement exclusion. I'm going to digress a bit and talk about this because it's one of my favorite topics. And I think it was one of the important changes in DSM. So what is the bereavement exclusion? Why was it introduced? Why did the DSM committee decide to scrap it? Why all the controversy about it? And that's been considerable controversy. And what does the DSM-5 do instead of having the bereavement exclusion? So those are the areas I want to cover here. First, what is it? It basically has said since 1980, since DSM-3, that if you're bereaved, even if you meet all the criteria for major depression, you may not be depressed. You may simply call it bereaved for at least 2 months. So at, day 59, after you've lost somebody, if you meet criteria for depression, you don't have depression at day 60 with the same symptoms you do. And that was the only life event that negated the diagnosis of major depression. Okay, so that was the bereavement exclusion. It was criteria E in the DSM-4, and basically it was stated that in order to meet criteria for to be diagnosed with major depression, the symptoms could not be better accounted for by bereavement. That is, they have to last at least 2 months after the death of somebody if somebody's died. There has to be marked functional impairment associated with it, and it has to be characterized by at least one of these symptoms: psychomotor retardation, morbid preoccupation with worthlessness, psychotic symptoms, or suicidal ideation. To call it depression if it's within this 2-month window after the death of somebody. Okay, so that was the bereavement exclusion. Why was it part of DSM-3, 3R, 4, and 4TR? It was meant to minimize the possibility of misattributing normal grief associated with the death of a loved one as a mental disorder. So the intent was honorable. Makes sense. Why would anyone want to, label or pathologize normal grief? And it was based primarily on the work and studies of Paula Clayton, who also happened to be on the DSM-3 committee. This is a summary of her data. Did a series of studies, mostly with widows and widowers, looking at depressive symptoms over time. And as you can see, in the widows and widowers, 1 month after the death of their spouse, symptoms that correspond to symptoms of depression were quite common. 3/4 of them had a sleep disturbance, 75% low mood, 44%, no surprise there, but a lot of depressive symptoms. Even a year later, although most of the symptoms decreased in time, they were still quite prominent. So half of the widows and widowers still had a sleep disturbance, 42% still had low mood, 30% fatigue, etc. Depressive symptoms were common. All of these symptoms, with the exception of worthlessness, were more common in bereaved than in married controls. So these depressive symptoms were related to the death of a loved one. You could feel worthless and still be married. So that one, interestingly, was not more common. The bereaved also, in one of her studies, one of the smaller ones, she compared bereaved individuals to inpatient depressives. And bereaved individuals, as you might guess, had less depression than inpatient depressives. They had less psychomotor retardation, less feelings of worthlessness, less suicidal ideation. And more than the inpatient depressives, they felt their symptoms were logical and not pathological. So the problem with this data in terms of DSM is that the controls were all wrong. The best control to look at the meaning of depressive symptoms in widows and widowers was not a married group, but would be of those who met criteria for depression, comparing those to married individuals who met criteria for depression. Were they different? And that wasn't it. I was just looking at bereaved individuals compared to married individuals. They had more depression than that. They were large. They were, pretty good-sized studies. I don't have them at the top of my head, but and there were actually 3 major studies, and most of this was collapse data. The inpatient study was small, but again, it's just not the right control group. You don't compare bereaved individuals who may or may not meet criteria for depression to, of all people, folks who are so severely depressed to warrant inpatient care, many of whom were psychotic. It doesn't tell you much. A better control would be outpatient depressives, or community-based depressives would be even better. So, but that was the data on which the DSM-3 ended up putting in the bereavement exclusion. There have been several studies since that have looked to see if it made sense, if the notion that depressive symptoms are fundamentally, after bereavement, are fundamentally different than depressive symptoms after any other life event or when they occur out of the blue. And those studies suggest there really weren't any difference. Also, the DSM-5 committee had the belief that the bereavement exclusion really created a roadblock to the diagnosis of a very important condition that might even be increased after loss of a loved one as a precipitant of major depression. And so based on the data, they ended up deciding to get rid of it. And we'll talk about that in a second. So consider this case. Mr. S is a 40-year-old, Miss S is a 40-year-old woman who reports gradually increased distress and despair that have become more disruptive over the past 6 weeks. She complains of persistent sadness and unhappiness. She's not able to enjoy or experience joy or pleasure in customary activities, has little appetite, she's lost 6 pounds. She awakens at 4 a.m., she feels restless and on edge much of the time, she can't think straight, has minimal energy, complains of no get up and go, she's avoiding friends and relatives, is inconsolable. Of note, she does not express morbid feelings of worthlessness, demonstrate psychomotor retardation, endorse psychotic symptoms, or experience compelling thoughts of killing herself. She's not able to work and care for herself. She is able to work and care for herself, but not as effectively as previously. So, what would her diagnosis be if these symptoms began after she learned that she had terminal cancer? Major depression. Right? She meets all the criteria. If she suffered a spinal injury that resulted in loss of function of arms or legs, horrible event. Major depression, we would treat it. She lost her job, was facing disclosure, major depression. If her husband was filing for divorce, major depression. If she had flunked out of medical school, major depression. If life was going well, major depression. But if somebody had died, grandparent, parent, sibling, spouse, child, anyone, not major depression because it's within 2 months, it doesn't have suicidal ideation, psychomotor retardation, or worthlessness associated with it. Does that make sense? Well, it only makes sense if the depressions occurring after bereavement are fundamentally different than others. And we've done 3 large literature reviews of all the studies available to look at that, and basically what we found is that depressions are identical, whether they're precipitated by bereavement or any other loss. They're also, the depressions that occur in the context of death of a loved one are every bit as likely to have those very symptoms that the DSM says are not part of normal bereavement, such as feelings of guilt, worthlessness, psychomotor retardation, suicidal ideation. A study done with Ken Kendler showed that they're as genetically influenced as any other depression. They appear in twins in the same way, and identical twins in the same way you would expect any other depression to. They're most likely to occur in individuals with past and personal family histories, just like other depressions. They have similar personality characteristics associated with them and patterns of comorbidity. They're every bit as likely to be chronic and recurrent, and they respond to antidepressant meds. So the DSM concluded that the bereavement exclusion should not be retained in DSM-5. It's been a controversial decision. I've never been involved. It was fun, actually. My name was smeared all over the internet for a couple of months. All over the world, actually. It was great. Our friend Alan Francis, former chair at Duke, and was also the chair of the DSM-4 task force. The day that it was announced that these changes were going through, said in the press, I think it was in the New York Times, "This is the saddest moment in my 45-year career of studying, practicing, and teaching psychiatry." The saddest moment. But this was terrible. And the main reasons were that he felt that this medicalizes sadness and grief, which I think is nonsense. It doesn't medicalize. If the loss of a loved one precipitates a depressive episode in a vulnerable person, how does that medicalize bereavement? It doesn't any more so than, bereavement's also been associated with the onset of cancers, breast cancer, for example. Just to acknowledge that doesn't medicalize bereavement. It says, gee, terrible life stress can bring on bad health events. Let's acknowledge that. Let's take it seriously. Let's deal with it. He also said, this is crazy because now what you're saying is the grief should only last 2 weeks. That because, if at 2 weeks you meet criteria for depression, you're depressed. Well, again, that's nonsense. This is not, Steve and I have basically done work on grief. It's a lifetime event for many people. It doesn't go away. It doesn't go away simply because you also have major depression if you also have major depression. In fact, it may make the grief worse. And it may be very useful to treat that depression to allow the person to go through a more normal grief response. And the other criticism is, the pharmaceutical industry, they're behind all this, and it's going to be a bonanza for them. And I venture to say I don't think we're going to see a single company go after an indication for grief. And in fact, the data that antidepressants help people with major depression in the context of grief has been around for about 30 years now. And it hasn't changed anything. No company's going after it. And just because a diagnosis of major depression can be made doesn't mean that pharmaceuticals should be prescribed. It means they have this disorder, diagnose it, and then consider what the best treatment may be, if any. Sometimes the best treatment is watchful waiting. That's true of major depression under any circumstances. And sometimes the best treatment is therapy. Sometimes it's meds. Sometimes it's both. Various things. Okay. So what is the DSM doing instead of having the bereavement exclusion? Well, I'm going to go through this because I think it's kind of interesting, and there's some lessons here. So one, on page 20 of the big book, the part no one ever reads, the first section, it defines mental disorders. And it says a mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotional regulation, or behavior. An expectable or culturally approved response to a common stressor or loss, such as the death of a loved one, is not a mental disorder. So basically, the bereavement exclusion is still there. If the clinician judges a response of a person to be consistent with their culturally approved response to a severe stressor, whatever that stressor is, defer diagnosis. Wait. So it's basically saying culture is important. Okay. It's still there. Approach to clinical care. So the DSM-5 has a chapter on formulations. Again, something that no one ever reads. And in that chapter it says it's not sufficient to simply check off the symptoms in a diagnostic criteria to make a mental disorder. The DSM-5 is making explicit this should not be used as a checklist by untrained clinicians. That does not give very valid diagnoses. A systematic check for the presence of these criteria needs to be done. So systematic check, detailed interview, the relative severity and valence of individual criteria and their contribution to a diagnosis require, and I put in bold, clinical judgment. DSM-5 says use clinical judgment. It's important, not just a checklist of symptoms. It then goes on to say the ultimate goal of a clinical case formulation is to use the available contextual and diagnostic information in developing a comprehensive treatment plan that is informed by the individual's culture and social context. These recommendations go beyond, treatment recommendations go beyond the scope of the manual. So the DSM says up front, we're not a treatment manual, but do an extensive formulation, not just a checklist of symptoms, before deciding how to treat an individual patient. In the Introduction to Depressive Disorders, page 155, careful consideration should be given to the delineation of normal sadness and grief from a major depressive episode. It says bereavement may induce great suffering, but does not typically induce an episode of major depression. But when they do occur together, the depressive symptoms and functional impairment tend to be more severe, prognosis is worse, compared to bereavement that is not accompanied by major depressive disorder. What this is saying is that the clinician doesn't need to decide, is this grief or is it depression? It's not an either or. Is this grief and also a major depression? And if also major depression is there, the grief is worse. That's essentially what this is saying. Okay. So the DSM-5 is actually dealing with the issue, but rather than a simplified bereavement exclusion that makes no sense whatsoever, it's basically encouraging clinical judgment. Okay. In the text itself now, under the diagnostic criteria, there is a note, and this is verbatim, this is what the note says. Responses to a significant loss, for example, bereavement, financial ruin, losses from a natural disaster, serious medical illness or disability, may include the feelings of intense sadness, rumination about the loss, insomnia, poor appetite, and weight loss noted in criteria A, which may resemble a depressive episode. Although such symptoms may be understandable and considered appropriate to the loss, the presence of a major depressive episode, in addition to the normal response to loss, should also be carefully considered. So two things to note here is that it's no longer saying just bereavement. It's now saying any loss can involve symptoms that overlap with those of a major depressive disorder. Bereavement is one example of such a loss. But just because you can understand that somebody may be sad or unhappy after a significant stressful event or loss doesn't mean if they meet full criteria, you shouldn't also diagnose that, the depression. Okay. That's what it's saying. I think those are important points. The DSM says right in the diagnostic criteria for major depression, I think this is critical, the decision inevitably requires the exercise of clinical judgment, which I put in bold, based on the individual's history and cultural norms. So the DSM, whatever you're diagnosing, should not be used as a checklist. Use it in the context of your knowledge and wisdom, not only about psychiatry and mental health in general, but of the individual patients, their family, their cultural context. DSM was great in doing this. I thought they really got it right. I'm going to have to skip this out of time. There's a footnote to the note in DSM that actually, to try and help clinicians distinguish between the dysphoria associated with grief alone and the dysphoria that may be present if the grief is complicated by major depression. So just an example. In grief without major depression, the predominant affect is feeling empty and alone. We just had a patient that we're interviewing for our complicated grief study whose wife died 7 months ago, who just kept talking about how alone, the loneliness, the emptiness, and that was his predominant affect. He didn't have major depression. I thought he should not go into our study because it would be wrong to give him antidepressant medications. He was grieving. Okay. In major depression, the predominant affect is a persistently depressed mood and or inability to anticipate pleasure, happiness. So there are subtle differences. The suicidal thoughts in grief are really, that's not complicated with depression, are focused on the deceased, possibly joining the deceased, wanting to be with them, maybe I should have died instead of the deceased. Whereas in major depression, suicidal thoughts are focused on that it's too painful to live, or I'm too worthless to live, I don't deserve to live. So worthlessness is a component there. So there are subtle differences. I'm going to skip the rest of this and just mention that in the DSM-5 there is also still a category, V-code diagnosis, for what's called uncomplicated bereavement. In DSM-4 it was called bereavement, now it's called uncomplicated bereavement, to signify that somebody may see a doctor for grief, and we can give them this V code of uncomplicated bereavement if they don't meet full criteria for major depression. And sometimes somebody may come in because they're not sleeping well, or they're anxious, or for other components of the grief that may be perfectly realistic, and we may see. But yeah.
What if people have some syndrome, depressive symptoms?
That would be treated just like if it had nothing to do with bereavement. So that might be an other specified. So that depressive disorder with insufficient symptoms for the diagnosis. And that would be true whether related to bereavement or not. Okay, next specifier with mixed features, and I gave you the criteria for mania or hypomania. If you're depressed and you also have 3 or more manic or hypomanic symptoms present every day or nearly every day, most of the time, most of the time during that depressive episode, it's with mixed features, okay? By definition, this is not meeting full criteria for mania, and the DSM warns us appropriately that when mixed features are present in the context of depression, that may be a forerunner of somebody who actually does have bipolar disorder, and that should be taken into account in terms of our treatment approaches, our planning, our monitoring of the patient. But it is still possible to have mixed features in somebody with a pure depressive disorder. Okay. With anxious features, this is another major change for both mania and depression, that one of the new specifiers is with anxious features. Now, anxiety is not one of the symptoms of depression when you're looking at diagnostic criteria, but it's very common, and when it's there, it's very meaningful. So the DSM bases anxious distress as having at least 2 of these symptoms: feeling keyed or tense, feeling keyed up or tense, feeling unusually restless, problems concentrating, fear that something awful will happen, and feeling that you might lose control of yourself. Okay, those are the 5 symptoms, at least 2 of those, and they also want a measure of severity, so mild severity if there are 2 of them, moderate for 3, moderate to severe if there are 4 or 5, and severe if there are 4 or 5 plus motor agitation. So why has the DSM decided to do this? It's because recognizing anxiety in the context of depression is very, very clinically important. Okay. This is some data from STAR-D, and basically says anxious depression is the norm. If we just look at on the far left, those people who had anxious depression based on elevated scores on a depression rating scale, 53% of those coming to treatment for major depression had anxious depression, independent of the comorbidity. A lot of them had comorbidity with anxiety disorders. This is independent, so 53%. Was that 53% different than anyone else? Well, we all know in STAR-D, remission rates sucked. They weren't very good. Well, they really weren't good if you had anxious depression. That 53% with anxious depression had less than 28% of them remitted within 14 weeks of treatment with high-dose SSRI, compared to almost 40% of those without anxious depression. Okay, huge difference. So remission rates were lower, response rates were lower. Even if you remitted, it took longer to get there, and even if you remitted, there continued to be more residual symptoms of anxiety and somatization at the end of treatment. And Dr. Judd has taught us well what it means to have residual symptoms. It means you're suffering, your quality of life sucks, and it also means your likelihood of relapse is substantially higher than if you don't have residual symptoms, okay? In addition, that group with anxious depressions were much more likely to not tolerate treatment or to have severe side effects. In terms of hospitalizations for general medical conditions, way more likely if you had anxious depression than non-anxious. Psychiatric hospitalizations for suicidality, way more likely if you had anxious depression. All 6 individuals in STAR-D who had made suicide attempts were in the anxious depression group. Okay. So acute, yeah.
How do you code the comorbidity then? So you give them depression with anxious features, but then you would also give them PTSD or OCD?
Well, you may. So in the comorbidity, that would be the same as it was. That's not a change from DSM-5. So you could give both diagnoses. But in the anxious depression is independent of comorbidity. So a lot of people will be anxious and be 2 of those criteria, but not meet criteria for GAD or panic disorder.
But do you code both?
So, yes. So if you meet criteria for the other anxiety disorder, you would still code both, just like you do in DSM-4. Okay.
Is it known whether adjunctive antipsychotic helps more with the anxious depression than the non-anxious depression?
No. Although a lot of people treat with atypical antipsychotics. It's not known that any particular class of antidepressants is more effective for anxious depressions versus others either. But we do know that whatever treatment you give is less likely to work in an anxious depression. Yeah. MAOIs, but there's very little new data on it, and there's very little data specifically. So there's the wisdom of those of us with gray hair that MAOIs are good for anxious depressions. But I'm going to have to rush through this. Jan Fawcett's work on which depressed people are most likely to make a serious attempt at their lives, that the single best predictor of imminent suicidality was not suicide intent, not past history, was anxiety. Severe anxiety predicts imminent suicidality in patients with major depression. So again, anxiety is important to recognize. So by having the anxious distress specifier, anxiety will be acknowledged rather than ignored in people with depression. Clinicians will be alerted to the slower and more difficult initial response to treatment, to the increased suicide risk, to the increased risk of relapse, and hopefully the idea of finding out which treatments are most effective, whether it be psychotherapy, other medications, combinations, can be done because we need better treatments. Okay. I just want to take 5 minutes or less on suicide in the DSM. I'll do this fairly quickly, but I think it's related. So one of the main reasons I think Jan Fawcett agreed to be the chair of the mood disorders work group is because he was so committed to getting suicide into the DSM and to actually both have suicide as its own independent diagnosis, since it crosses boundaries of all diagnoses, and also to have physicians rating suicidality as part of their daily practice. So there were 2 proposed scales, one for adults, one for teens, and there were 2 proposed diagnoses: suicidal behavior disorder for somebody who had made a suicide attempt during the past year, and non-suicidal self-harm for somebody who had made self-injurious attempts without the intent of killing themselves during the past year. Those were the proposals, both of which were moving along quite well throughout this entire process until the end point. Part of the rationale is the knowledge that currently suicide risk scales don't really predict who's going to kill themselves. So despite decades of work, there's no algorithm that can predict suicide in an individual patient. We can predict risk factors. We can put people in categories of high risk, but we can't produce which person at what point in time is going to try and kill themselves. So we can't yet identify which individuals.
What about the work of Aaron Beck?
Well, hopelessness is a risk factor. But if you hospitalize people on the basis of hopelessness, most of them aren't going to try and kill themselves. And does it predict who's going to kill themselves within 2 weeks? It's modest in terms of, so it's one of the factors, despair, hopelessness, helplessness, in the context of major depression, but we're still not very good at predicting. The Institute of Medicine in 2000, after their review, said currently available tools are inadequate to determine suicide risk or predict which patients will kill themselves. The conclusion was longitudinal and prospective studies are needed. That was in 2000. A couple months ago, the U.S. Preventive Services Task Force basically reviewed all of the data, especially that occurring since 2000, and concluded, after completing a systematic review of the evidence, the task force concluded there's not enough evidence to make a definitive recommendation for or against screening, because we just still haven't found the predictors. Alan Berman, Executive Director of the American Association of Suicidology, his quote recently, although intuitively pleasing and appealing to a clinician's common sense, there's no research evidence to support the proposal that active suicidal ideation, with or without a plan, predicts greater risk for suicidal behavior than does passive ideation, than does denied ideation. So the DSM, with Jan Fawcett's leadership, really wanted to do something about this and develop a diagnosis so it could be studied and use screening tools for every patient, regardless of diagnosis, so that we could learn more about it. And I won't go into what their proposals were because we don't have time, but basically the field studies showed there wasn't very much reliability with what they came up with, and the final scientific committee basically decided against all of the recommendations. So neither of the adult scales were included, and probably our understanding from people in the inn, and maybe Dr. Swang has more information, that was a legal decision. The lawyers felt that we just weren't ready for it, that too many problems could arise, and despite the need. As a compensation prize, the description of, in several diagnoses in the main text include a paragraph about suicide risk, but it's not a required part of, there's no diagnosis for suicidality, and neither of the proposed diagnoses made it into the core of DSM. They both, though, were included in Section 3 as conditions for further study, which helps because it's easier to write a grant. If you're in that part of the DSM, there is a condition, there are criteria, and it can be studied. And maybe the hope is that in DSM 5.1 or .2, there will be a category of suicidality and suicide risk that is up center in front, and it's probably one of the more important diagnoses that we as mental health clinicians will be using. Skip that. I guess we have a few minutes left, and it went longer than anticipated. Yes?
That was incredibly informative. On the STAR-D slide comparing anxious depression to non-anxious, you noted that people with anxious depression responded worse to psychopharmacological treatments, but there was a STAR that said they responded equally well to psychotherapy.
No. I'm glad you mentioned that. In addition, so the question is, so in STAR-D, there was also the possibility of either getting switched after a failed attempt with SSRIs to cognitive behavioral therapy or to be augmented with cognitive behavioral therapy that was well delivered by people who were well trained. And the same results were there. So the people with anxious depressions did far worse with cognitive behavioral therapy in addition. So whatever your treatment was, whether it was treatment with another SSRI, whether it was treatment with venlafaxine, whether it was treatment with cognitive behavioral therapy or bupropion, any of the treatments, and whether it was augmenting or switching, if you had anxious depression, you did worse. Yeah?
I think I'd like to share with you being in the psychosis task force. What you mentioned is consistent throughout the I think, 4 years of the labor. And the attenuated psychotic syndrome, formerly called prodromes. We wrestled with this for a long time, and I was responsible for that in creating the criteria. But finally, it was voted down to be on a category 2 if we stay to the appendix. The reason is research is being carried out. We have to wait for the more research data. So it is very important that the suicide is currently the literature which you review seem to feel that depression is not necessarily the sine qua non is the suicide. But recent literature, the more you review, depression plus impulsivity is very, very important clinical part of it, which you should learn.
Yeah.
And another thing which I like to stress particularly is a resident. With this DSM criteria, we still need to have the good clinical training and good experience, which is the clinical judgment that throughout my work or the workforce, everyone stress that clinical judgment is very, very important. So don't let the other discipline or the medicine saying that now you have this criteria, you don't need training. Training is still very, very important.
Yeah. I think it's wonderful that the DSM, I think one of the positive things is the emphasis that they have put on clinical judgment. And it was there in other versions, but it was hidden. Here it's up front and I think very useful. Barbara?